And now the main question is, patients with multiple nevi, which lesions should be monitored? We have answered the questions, which lesions should be looked after with the dermoscope, almost every lesion, but which lesions should be monitored? You know that sequential imaging is very simple. You have a computer, a dermoscope connected to a computer, and you can easily compare images that have been taken over time. And this is the only advantage. There is no other advantage. The image quality usually is worse than with the dermoscope. So the only major advantage of the systems is that you can easily store it, retrieve it, and put it in a computer system. That's the main advantage. And the problem is we should not use the follow-up if we are insecure, because we don't know dermatoscopy. This lesion, although it's small, there is no indication for monitoring, because the diagnosis of a melanoma can be made easily at the first visit. You should not monitor it. Yeah? There's no need to do that. But sometimes the situation, even especially when we go back in the history, is not so easy. For example, in this patient. He has multiple moles, and he probably has one melanoma. And the question is now, which one is the melanoma? Which lesion to look after with the dermoscope? Which lesion to excise? And if no lesion should be excised, which lesion to monitor? Which of the 6 lesions would you excise? Every lesion? Only 1? 2? How many? Well, it's only a guess, because if the patient goes to 6 physicians, 6 dermatologists, everybody would say something else. Yeah? This happens all the time. The patients go to another dermatologist, and he says, this one, and another one says, no, this one. This happens to these patients. You know that very well. And in former days, we did the following. We excised as many lesions as possible at the first visit of the patient. Boop. Yeah? This is Photoshop excise. Yeah? No scars. Very well done. Yeah? So if the patient comes back, we excise another 10 or 20 lesions. Usually then, the patient won't come back to you, yeah? Because he has enough scars. Yeah? He has enough of these procedures, and you only pick a melanoma by chance, yeah? And not by knowledge. So, and you do not alter the risk of these patients to develop melanoma, because these patients still have an increased risk of melanoma, even if you excise all these nevi, because the risk of melanoma development does not lie within the nevi. It lies within the genes. You cannot remove the genes. Yeah? You can only remove nevi. So what we do is we monitor, like in Rome, and by monitoring we have additional information that is not present at the first visit of the patient. And if we go back, lesion 2 is the melanoma. How do we know? Because it changed over time. There's an increase in size, new color, new structure. The melanoma. Yeah? So follow-up adds diagnostic information, as you have already seen. I'll show you some examples of melanomas that cannot be diagnosed with dermatoscopy only by the information or by the additional information of monitoring. Would you diagnose a melanoma here? But now? Yes. Yeah? Increase in size, asymmetric increase in size, new structure at the periphery. Melanoma. Impossible to diagnose with the unaided eye, impossible to diagnose with dermatoscopy, only possible to diagnose with monitoring. Cannot be diagnosed earlier. So why do we need monitoring? To diagnose melanoma as early as possible. This is a lady I know very well. She's the typical lady with multiple moles, an increased risk of melanoma. And here's the lesion. This is the lesion. Increase in size, melanoma, very early. But this lesion has a history. This is the lesion here. And this was one of our first patients' follow-up. Here you can see the history of this lesion. And here you can see when we started monitoring. In June 1997, we were the first, not really, Garber started 1 month later, but essentially we were the first to monitor melanocytic lesions with digital dermatoscopy. And you can see at the beginning, we didn't know how to interpret the changes. We we set up 3 months monitoring, and you can see the lesion changed. We ignored it. Then after 3 months again, the lesion changed. We ignored it because we expected to see a lot of changes, even in nevi. And then in April 1998, we excised it, and it was a melanoma. It was a melanoma here. It was a melanoma here. It was a melanoma here. And it was a melanoma here. So, and this is a major message. With digital monitoring, you do not monitor nevi, because the chance of a single nevus to transform into a melanoma is practically 0. What you do is you monitor melanoma, which means you monitor melanoma that do not have dermoscopic criteria at the first visit of the patient. And this is a major difference. Yeah? People always think we monitor nevi. Yeah? Of course, we monitor much more nevi than melanoma, yeah? Because we monitor a lot of lesions. But essentially, we try to catch early melanomas. Another patient, where's the ugly duck? Say stop when there is the ugly duck. Ah, I'm sorry. No, I spoiled it. Yeah? Well, here's the ugly duck, but here's the melanoma. Yeah? This is the change over time. Yeah? So not every time the ugly duck leads you to the diagnosis of melanoma. You see eccentric hyperpigmentation, but this patient has a lot of lesions like that. First visit, second visit, you can see always the same pattern, increase in size, but also a new structure, and almost always at the periphery, never in the center. If there is change in the center, it's not so important, always at the periphery. Another example here. Of course, this was a melanoma at the first visit. You can see radial lines at some segments, which is a clue to melanoma, but they are more obvious here with the follow-up image, melanoma in situ. You see the difference? Here you can see a reticular lesion, and then a nodule appears. Unfortunately, this patient waited 3 years to come back. This shouldn't happen. Usually we tell the patients to come back after 3 or 6 months, not after 3 years. But the patients sometimes do what they want, not what you want. This is another example. This is a 1 millimeter bar. This is a 4 millimeter lesion. You can see an increase in size and a new structure here appearing, melanoma in situ. This is another example. Doesn't look like a melanoma here. Very small lesion, eccentric hyperpigmentation develops, melanoma in situ. Sometimes there is no increase in size. There is only a new structure. For example, here the black dots appeared over time. They were not present at the first visit of the patient. Melanoma in situ. Sometimes you have to look very closely. Very small lesion, 4 millimeter, 3 millimeter. And here you can see an increase in size, and it's now it can be diagnosed as melanoma in situ. We did not diagnose these melanomas 10 years ago. Yeah? We called them, when we saw them, we called them atypical nevi, yeah? Because they looked like nevi, not like melanomas. Another example, 4 millimeter lesion, change in size, a new structure. Which new structure? Black dots at the periphery, which is a clue to melanoma. Melanoma in situ. Another example here, it looks like an atypical nevus, but atypical nevus only means we're not sure. It could be an early melanoma, and it's good. Yes, we are not sure, but the nevus is sure, but it's not a nevus, it's a melanoma. And here is the change over time. Yeah? Some of you, and this always happens when I give presentations like that, some of you might say, well, what are you doing here? You're monitoring melanomas. We would have excised those melanomas at the first visit of the patient. Well, I said, maybe you are much better than I am with dermatoscopy, so let's make a little test. Yeah? We tested 20 dermatologists who are all very experienced in dermatoscopy, and we showed them the baseline images only of nevi, but also of melanomas, not the follow-up images. More than 260 nevi, more than 60 melanomas, and only the baseline images. And they had to indicate whether the lesion is a melanoma or it is a nevus, or whether they would excise it or leave it. So now what do you think, what do you estimate was their sensitivity? Well, I can tell you, this is published, 27%, which means they had to expect there were some melanomas in the sample, it's not better than just guessing. No? So you cannot diagnose those melanomas at the first visit of the patient because they don't look like melanomas. They look like nevi.